My name is Dr. Douglas Frank. I thank you for your attention. I am part of the Division of Head and Neck Surgery in the Department of Otolaryngology at the Zucker School of Medicine at Hofstra Northwell. And we treat patients in the division all throughout Long Island and in Queens. And again, I thank you for your attention. First, a little bit about some basic anatomy. The head and neck is covered with skin, and we're going to spend a good amount of time talking about that. And also what's underneath the skin of the neck, which consists of muscles, blood vessels, lymphatics off to the sides of the neck, and in the middle, the thyroid gland. Here's another picture of the anatomy of the middle of the neck that shows the thyroid gland situated in the middle. And off to the side, we see a couple of the major muscles of the neck, both on the right side, this would be the patient's right side, and the patient's left side. Underneath these muscles sit the blood vessels of the neck, the fatty tissue of the neck, as well as the lymphatic tissue. One thing you need to know, or that I need to know when I see a patient with a lump or a bump in the head and neck, is based on the age of the patient, based on where the lump or the bump occurs in the neck, based on how acutely the lump or the bump appeared, I, as well as people in my field, have a pretty good sense of what's going on with that particular patient. Here you see two patients. The patient on the right is a middle-aged man with a lump in the upper part of the neck. And I immediately begin to think what the potential diagnoses could be in that patient, which are very different from the young girl in the picture on the left who has a similar lump, albeit on the opposite side of the neck. But what I'm considering in that patient as potential etiology of that lump or bump is very different than the patient on the right. So when I see someone with a lump or a bump in the head and neck, which, like I said, includes the skin, as well as the structures underneath the skin of the head and neck, I consider the patient's age, their ethnicity, and what are some associated signs and symptoms associated with that lump or bump? Is there fever? Are there night sweats? Are there swallowing problems? Are there breathing problems? Is there any bleeding associated with it? What are the duration of the symptoms? And me coming up with a potential diagnosis for what that problem is. The examination is important in helping me determine what the problem is, the location of where the mass is in the neck. Are there other physical findings, such as skin lesions associated with the lump or bump in the head and neck, independent of it? Is there overlying skin change or discharge? Is the lump or bump tenderness? Is it fixed, meaning not mobile? In addition to the physical examination, there are other ancillary studies such as ultrasound, CAT scanning, MRI scanning, and PET scanning that me and my fellow clinicians may order to help us determine what the diagnosis is. This slide shows a timeline based on age of when common lumps and bumps in the head and neck appear. And to the left of the timeline, in the younger ages, the pink boxes, these are mostly conditions that occur in younger patients, and these are mostly infectious and inflammatory conditions. As you get older, and these are the boxes in the blue, lumps and bumps in the head and neck tend more frequently to be tumors. And by tumor, I don't necessarily mean something that's cancerous. You can have non-cancerous tumors as well. But the older you get, a lump or bump in the head and neck that appears, and particularly if it doesn't appear suddenly, but over a period of time, is more likely to be an abnormal growth of cells, be it cancer or non-cancerous growth. Kind of taking the younger group out, and the diagnoses that were in the pink boxes, which focused more on the infectious inflammatory conditions, these are this is really a summary and the most common types of cancerous and non-cancerous lumps and bumps that can happen in the head and neck that include cancers of the skin as well as the underlying structures. And I want to point out that when I refer to head and neck, I'm excluding the brain and the spinal column, but everything else is part of this. Everything else is part of this discussion. So, skin cancers, thyroid nodules and thyroid cancer, metastatic cancer, cancers that appear in the lymph nodes of the neck but come from other parts of the body, including some of the structures of the head and neck, salivary gland tumors, as well as lymphomas, and another classification of tumors that tends to happen in the younger age group called small round cell tumors. All these are types of tumors that can occur in the head and neck. And amongst the thyroid tumors, I want to point out that the vast majority of thyroid nodules in adults and young adults, older adults, are benign. With salivary gland tumors, depending on the salivary gland that the tumor is in, particularly the larger salivary gland tumors, the majority of these tumors are benign as well. So I don't want you to think that just because you have a lump or a bump in the head and neck in the thyroid gland or in the salivary gland that it's necessarily cancerous. Certainly it could be, and it needs to be evaluated by a physician, particularly if you can feel it. But it's not necessarily a cancer. It's important to point out that amongst the common cancers, some of the most common that happen in the adult population do frequently occur in the head and neck region, hence the relevance of this discussion. The number one cancer that occurs in the body are skin cancers anywhere, including the skin of the face, the scalp, and the neck. And because of the exposure of the face and the scalp and the skin to the sun, this is one of, if not the most common place for skin cancer to occur in the body. And overall, skin cancers, as I said, are the number one cancer that befalls man. Thyroid nodules are extremely common, and we'll see in a subsequent slide up to half of adults, if you just screen them with sonography, which we don't routinely do, may have some sort of architectural abnormality in the thyroid gland. But a thyroid nodule or thyroid bump and thyroid cancer is very common in women. And in fact, thyroid cancer is the number 4 cancer in women in the United States. Metastatic cancer from the thyroid gland, from the throat, as well as from the skin, can present underneath the skin and even invade through the skin, and that can present as a lump or a bump in the head and neck. And lymphoma can present in the lymph nodes of the neck and present as a lump underneath the skin. And that is the 7th most common cancer in men and women in the United States is lymphoma. We'll get into these in a little bit more detail. First, let's talk about skin cancer. And as I said, skin cancer is the number 1 type of cancer that affects mankind. And this is particularly true in the United States, where we have a large fair-skinned population. Let's talk about basal cell cancer and squamous cell cancer first. So those are the 2 most common types of skin cancers. Basal cell cancer is the most common cancer state in the United States, and it affects about 2 million Americans annually. And it exceeds the incidence of all other cancers combined. And I'm not just referring to the head and neck. I'm referring to skin cancer throughout the whole body, the head and neck just being a very common site of presentation. Basal cell cancer tends to occur in the head and neck, and it's several times as common as squamous cancer. Although squamous skin cancer is extremely common, basal cell cancer is much more common. 80% of basal and squamous cancers occur in the head and neck, hence the relevance of this discussion and your ability to recognize it and seek care immediately and get screened by a dermatologist, particularly if you're fair-skinned and you've had a history of sun exposure. So fair-skinned people, red or blonde-haired individuals, individuals with light hair, color, and cumulative sun exposure. These are the most common risk factors, and they're all associated with the development of skin cancer, particularly as we get older. The treatment of skin cancer, when there's a suspicious growth, starts with a biopsy done by a primary care physician or a dermatologist or a head and neck surgeon like myself. That biopsy is very often followed by appropriate removal by an appropriately trained physician. And more advanced and recurrent basal and squamous skin cancers may require additional treatment, sometimes radiation therapy, sometimes systemic treatment. And prevention via public education is a key element of management of skin cancer, and dermatologic body checks by an experienced dermatologist on a regular basis, particularly for those individuals who are at risk to develop skin cancer, is fundamental to prevention. And in this shot, these are various products that can be picked up over the counter in a pharmacy to protect at-risk individuals from getting skin cancer. And sun protection really needs to start at a very, very early age, in adolescence, in the teenage years, and needs to continue in adulthood. Whenever there's going to be a prolonged or intense exposure to the sun, one needs to protect themselves. And there are many brands and varieties of skin protection products available to prevent skin cancer. Recognizing a basal cell cancer is actually fairly easy. This is a very common presentation of a common type of basal cell skin cancer that can certainly occur and present as a growth on the skin of the face and the scalp and the neck. Basal cell will often appear as a waxy, nodular lesion with an umbilication or an indentation in the middle. It almost looks like a little button. And when you see a growth like this, it's almost certain to be a basal skin cancer. However, there can be other presentations that may not have this classic appearance. This is a morphea type of basal cell cancer. It can just look like a red, kind of an itchy growth with ill-defined borders, unlike the prior growth. That is on the picture on the left. And the picture of the right, it just might appear as a red, small red papular lesion, maybe with a little bit of a waxy appearance, or maybe in combination with the morphea type, you may see a nodular type as well. Squamous skin cancer may often be ulcerated, as is the case in the picture on the upper left and on the upper right. It may crust over. It may be ulcerated in the middle with a surrounding kind of spreading red border off to the side. It can often be very, very painful and itchy. The growth on the bottom shows that these lesions of squamous cancer might be raised, and very often what you think might be a squamous cancer might in the end turn out to be a basal cell cancer, because sometimes they can have a similar appearance, and vice versa. Squamous cancer, particularly when it presents in the head and neck, unlike basal cell cancer, has the ability, when it's advanced, to spread to the lymph nodes. And in this particular patient, this patient had an advanced skin cancer on his temple that was treated about a year before he popped up with this lump in his upper neck underneath his ear. And what this lump represents is spread of that skin cancer to the lymph nodes in his upper neck. And what happened is that that lymph node spread began to ulcerate through the skin. Melanoma, although much less frequent in its occurrence relative to basal and squamous cancer overall in the body, and particularly in the head and neck, and although it is less frequent, it is a potentially much deadlier disease, particularly relative to squamous cancer. In 2016, there were at least 76,000 new cases of melanoma were diagnosed in the U.S., and about 10,000 people die of this disease annually. Melanoma is a very common cancer with a very high death rate. And that needs to be made clear. Thus, early diagnosis and early recognition are key to fighting and curing this disease. The head and neck, as I stated, is a very common site of disease occurrence, especially in men. And risk factors for melanoma basically include the same things that are risk factors for basal and squamous cell cancer, and that includes fair skin, prior history of melanoma, multiple atypical moles or nevi, as well as some genetic predisposition and familial presentation. The thinner and the earlier the growth, the better the prognosis. Thus, the earlier a lesion is suspected of being melanoma and appropriately biopsied, the better the prognosis. Again, just like basal and squamous cancer, prevention via public education is a key element of management, and dermatologic body checks on a regular basis, particularly by those individuals at risk, are paramount for early diagnosis and cure. Remember, the thinner the lesion and the earlier it's diagnosed, the better the prognosis. And management after biopsy is typically surgical removal by a trained professional, either a dermatologist or a head and neck surgical oncologist or a surgical oncologist with particular expertise in the management of head and neck tumors, and with assessment and treatment of the lymph nodes at risk after appropriate diagnostic imaging. For thicker lesions and more advanced lesions with respect to melanoma in the head and neck, the lymph nodes are almost always at risk, and that needs to be taken into consideration in the management plan. I just want to show you some pictures of the various appearances of melanoma. Sometimes it can appear just like a scaly, raised growth that one could think they've had for a while, and one could think it's what's called the seborrheic keratosis, but that could be a melanoma, and that's shown in the upper panel diagram here. On the lower left panel, this is sort of a more classic appearing lesion, particularly when it's been something that changed. You can see the growth here. It's dark and more pigmented in the middle. It's kind of a little less pigmented on the periphery with irregular borders, and that would always be concerning for a melanoma, particularly for a growth that's changed. And on the growth on the right, with that variegation with various, it's raised in some areas, it's flat in other areas, it's dark in some areas, it's pale and sort of less dark in others, that would be very, very concerning for melanoma. And you also notice that the borders of the growth are somewhat irregular. I would be very concerned about that growth in the office for a malignant melanoma. And these are sort of some of the classic appearances, because these are the appearances that people associate with melanoma, some pigmentation. But if you look on this slide here, particularly the panel on the right, that growth is not pigmented at all. So sometimes melanoma, which really can masquerade as something else, can have a non-pigmented appearance. Clearly that is an abnormality of the skin and should be biopsied. It is ulcerated, it is raised. Sometimes these growths can be painful. This was indeed an advanced melanoma in this particular patient, and this has a more nodular and a more classic appearance of a melanoma. These are just some pictures of them. Everyone is always worried if they have a skin cancer, and it's reasonable in the head and neck. And our challenge as surgeons and practitioners who treat cancers in the head and neck is that when one has a growth such as a skin cancer in the head and neck, a basal cell cancer, a squamous cell cancer, and a melanoma, that surgical removal is going to result in significant cosmetic deformity. And that is very largely and almost uniformly untrue, and particularly for smaller and intermediate-sized tumors. You can see in this panel here, this individual had a pretty sizable skin cancer in and around the lower face, and that was removed. And particularly in older individuals where there's a lot of laxity in the skin could be repositioned and advanced in such a way that once it heals, as shown in this lower panel here, the incision can blend in with the natural skin creases and almost be inapparent with time. Some more images here of the management of a skin cancer in the nasolabial region, just through taking advantage of the natural skin creases and moving skin around. After removal of the growth, the tumor can be removed and the skin repositioned in such a way, such when there's ultimate healing, as shown here in the bottom right panel, that where the cancer was and the repercussions of the surgical treatment are almost inapparent. Same here, a small skin cancer on the lip. It can be removed and the skin repositioned and closed in a cosmetic way so that with time, the surgical defect and the scar with time are almost inapparent. So I guess what I'm trying to say here is if you have a growth, get it checked out. If it's a skin cancer, it can, in almost all instances, be managed in such a way so that when the growth is removed, that there's very little, if no, cosmetic disfigurement. And just again, to emphasize my point, the key to prevention of getting a skin cancer, whether it be a basal cell cancer, a melanoma, or a squamous cancer in the skin of the head and neck that includes the scalp, the face, and the neck region, is prevention. Dermatologic checks, particularly if you're someone at high risk, someone who has fair-skinned, light hair, and light eyes. Since thyroid lumps and bumps and nodules and thyroid cancer is so extremely common, I feel that we should spend a little bit of time talking about this in the context of common lumps and bumps in the head and neck. This particular patient here, and this is a very common presentation of a thyroid mass or even just a benign goiter in a middle-aged female. She had 3 years complaint of an enlarging, non-tender, low central compartment neck mass. This could very well be just a benign enlargement of the thyroid gland, or what's called a goiter, which means, enlargement of the thyroid. But given the timeline, given how it appeared over a relatively short time, given how it was growing, we would be very suspicious that this was a thyroid cancer, particularly on palpation if it didn't move very well. And indeed, that's what this was. And on this young woman, and thyroid cancer is very often presents in young individuals, and it's a very common type of cancer in a young woman. She actually presented with a lump in the side of her neck that represented spread of the cancer from a primary site in the thyroid gland, which we could not feel, into the lymph nodes of the neck. So if I see a young woman with a palpable lump in the side of the neck, one of the first things I think about, given the frequency of thyroid cancer, is thyroid cancer that spread to the lymph nodes in the neck. And indeed, that's what this patient had. And the treatment for both of these patients is appropriate surgery, which would include thyroidectomy. Sometimes we remove all of the lymph nodes, and sometimes that's followed up with a radioactive iodine treatment. How we diagnose thyroid cancer is actually very simply because a lot of times it presents as a lump or a bump underneath the skin, as I showed you in the various locations on the prior slide. And what can be done right in the office is with a needle that's no thicker than an acupuncture needle, we can, under ultrasound guidance, and sometimes not if the mass is big enough, do what's called a fine needle aspiration biopsy, where we take some cells out of the mass, put the aspirate on a slide, and have an experienced cytopathologist look at the slide and tell us what the diagnosis is. But again, I want to reiterate that many lumps and bumps in the thyroid gland itself, and in fact the majority, depending on the timeline, are benign. So I don't want you to hear this discussion, see this discussion, and think because you've had a long-standing lump in the thyroid gland, or you have many lumps and bumps in the thyroid gland, that it is necessarily thyroid cancer. Most lumps and bumps in the thyroid gland itself are benign, particularly if they've been present for a long period of time and you've known about them. It doesn't mean that they shouldn't be occasionally evaluated with ultrasound or the occasional biopsy. It means that it's more likely to be benign. But a lump or a bump that appears suddenly, that grows relatively rapidly over a long period of time, a lump that is found in isolation, particularly in a male, that more often is thyroid cancer and needs to be addressed, as well as a lump adjacent to the thyroid gland, but in the adjacent lymphatics. That is the side of the neck. Just some additional facts about thyroid nodules and thyroid cancer in general. Thyroid nodules, cancerous and benign, are much more common in women and in men, although certainly thyroid disease, thyroid nodules, and thyroid cancer is relatively common in men. When thyroid glands are randomly studied with ultrasound or at surgery, up to 50% are found to have thyroid nodules. And again, typically benign. Palpable thyroid nodules are noted in up to 5% of people over the age of 50 in the ultrasound if one is palpating the area close enough on a routine physical examination. And again, vast majority are benign. Thyroid cancer, again to reiterate, is the 4th most common type of cancer in the United States, with a peak incidence in middle age, around the age of 50. And in people between 20 and 34, this is an important statistic. And perhaps surprising the most, thyroid cancer accounts for 15% of all cancers. And there were about 62,000 new cases of thyroid cancer in 2015. But only a minority of people actually die of thyroid cancer, whether treated or not. And that's important to know. Thyroid cancer is an incredibly curable disease when appropriately treated and or followed. For small, early-stage thyroid cancers in what we call low-risk patients, sometimes those can be followed in an appropriate active surveillance program. But the vast majority of thyroid cancers are treated surgically, and those patients are under the care of a head and neck or a head and neck endocrine surgeon and an endocrinologist, and that's what we would encourage. A little bit more about the facts on thyroid nodules and thyroid cancer. Benign nodules, as stated, can often be followed without surgery, and we only reserve surgery for benign thyroid disease for large nodules or large goiters. And you can imagine if someone has a large mass sitting in the thyroid gland, sometimes it's not only cosmetically unappealing, but it can press on the central compartment structures of the neck, such as the airway, sometimes the esophagus, cause a feeling like there's a lump in the neck, or sometimes even cause swallowing problems. When there is concern for cancer, even though we don't have a diagnosis of cancer specifically in the thyroid nodule, and sometimes a biopsy can suggest that a nodule is thyroid cancer, sometimes in that instance we'll do surgery as well, either a thyroid lobectomy or a total thyroidectomy, depending on the location of the nodule or nodules. Known cancerous nodules are typically managed with surgery, as I stated, but not necessarily removal of the total thyroid gland, depending on the size of the nodule, the age of the patient, and what we consider to be either low or high risk factors. People with thyroid cancer are typically managed, as I stated, by a head and neck or thyroid surgeon and an endocrinologist. And people with benign nodules can be followed often by their primary care physician and an endocrinologist or a head and neck and thyroid surgeon when appropriate. But benign disease, particularly when it's not voluminous, those patients can often be followed by a primary care physician and not necessarily need to see a specialist. The lymphoproliferative disorders, which include the lymphomas, can often present as a lump, and do often present as a lump or a bump in the head and neck. And in this image right here, we show a young patient with multi-level lumps in the side part of the neck. This was a young female. She had a 5-month complaint of multiple masses in the posterior and side part of her neck. She had occasional fever and had some night sweats, and she had a 10-pound weight loss. And often with this history and these physical findings, someone in my field would immediately be suspicious of either an inflammatory condition or a lymphoproliferative disorder, and in her age group, specifically Hodgkin's disease. To show this slide again, the first step in diagnosis, besides the good history and a good physical examination, is a fine needle aspiration biopsy that can be done in the office or under ultrasound guidance, and having that aspirate evaluated by an experienced cytopathologist who can give us who could give the clinician a clue as to what's going on, the diagnosis, and us being able to let our patients know what the next steps are. Just some facts about lymphoma. There are 2 types. There's non-Hodgkin's and Hodgkin's types. Very often they are epicentered and can start in the head and neck region, so to speak, or be diagnosed in the head and neck region. Although this is regarded as a systemic disease, very often it initially presents as a lump or a bump in the side part of the neck, or sometimes even in the salivary glands off to the sides of the face where the major salivary glands sit. For the non-Hodgkin's lymphomas, there are 72,000 new cases reported in 2015 in the United States, with about 20,000 cancer-related deaths. It's the non-Hodgkin's lymphoma is the 7th leading cancer type in men and women in the United States, with a peak incidence in the 6th and 7th decades of life. So non-Hodgkin's lymphoma is a disease of middle-aged and older people, particularly in the United States. And treatment for non-Hodgkin's lymphoma, it is not a surgical disease, even though surgeons such as myself are typically involved in getting diagnostic information for the ultimate treating physician. Treatment can often be chemotherapy or systemic therapy, radiation therapy in certain instances, and combinations with chemotherapy and radiation therapy under specific certain circumstances. For low-grade or some of the chronic lymphomas, very often the treatment is just surveillance with no active treatment unless the disease changes or progresses with time. For the Hodgkin's lymphomas, the peak incidence is between the ages of 15 and 30. That's the first peak. And then there's a second peak in incidence in middle age over the age of 55. Hodgkin's lymphoma is less frequent, much less frequent in incidence relative to the non-Hodgkin's lymphomas. There were 8,300 new cases reported in the United States in the middle part of the last decade, with about 1,000 cancer-associated deaths. But the thing about Hodgkin's disease, and many of the non-Hodgkin's lymphomas, is that it is felt to be curable in a majority of cases, and that's important to point out. So the diagnosis of a lymphoma does not necessarily imply a fatal diagnosis. Back to this patient who we showed earlier in the talk, and if you'll recall, I showed two patients. One was a young girl who had a similar appearing right mass on the right side of her neck, and this middle-aged gentleman with an upper neck mass, but presenting on the other side, but in a similar or a mirror image location. In the young girl, that turned out to be actually an infectious condition presenting in the lymph nodes. But when I see a middle-aged adult male with a lump in the neck here, the first thing I think about is cancer that came from another site, probably from somewhere in the upper digestive tract, implying the mouth or the throat. This patient was a 58-year-old male. He had no history of smoking or alcohol abuse, and he had several months history of an enlarging left upper neck mass and mild throat discomfort. And this is going to kind of lead into a discussion about a disease that is endemic in middle-aged men, particularly in the United States, but in other places in the world as well. So we did a fine needle aspiration biopsy of the mass in this gentleman, in addition to a good history and a physical examination. That aspiration cytology showed us that he had squamous cell carcinoma, but in addition to that, our evaluation in the office revealed that he had a cancer originating in his tongue base. And the tongue base, as well as the area of the tonsils and the soft palate, is a part of the throat called the oropharynx. And the majority of air digestive tract cancers, which are mostly squamous cell cancers, and squamous cell cancers in this particular region are most commonly caused by infection with the human papillomavirus. It frequently presents as a relatively painless upper neck mass in middle-aged males. And as I stated, this disease is now considered endemic in the United States, and it can occur in non-smokers and non-drinkers, which was the typical demographic for this disease decades ago, and is a typical demographic when squamous cancer occurs of the oral tongue or of the voice box. But in that part of the throat called the oropharynx, where the base of tongue and the tonsils sit, particularly in middle-aged males, human papillomavirus is the causative agent. And if I see a patient with an upper neck mass, whether it's on the left side or the right side, whether the mass is mobile, whether the mass is fixed, the first thing I think of is human papillomavirus associated disease. There is a vaccine that is available for prevention of getting this cancer. It has been available for use in adolescent boys. It is the same vaccine, Gardasil, that is being administered to adolescent girls, because the same virus can cause HPV-associated cervical cancer. Treatment for HPV-associated oropharynx cancer, it can involve surgery or radiation plus or minus chemotherapy, sometimes both, depending on the stage of the disease, depending on the exact location, and depending on the volume of the disease. But it needs to be pointed out that squamous cell carcinoma of the oropharynx associated with HPV relative to its counterpart in the smoking population where HPV is not associated, particularly when this disease occurs in the oropharynx, the prognosis is excellent. 80 to 90% of patients are cured of the disease and disease-free at 5 years, whereas those statistics are much less in the population where HPV is not associated with the cause of the disease. The advent and the frequency of HPV-associated oropharynx cancer has caused there to be great innovation in the way this type of throat cancer and other types of throat tumors are managed. It's led to a revolution in the use of robotic surgery in the head and neck, particularly in the management of oropharynx cancer, where for smaller tumors and for tumors that are in locations where removal will not result in significant morbidity, these tumors can often be removed as opposed to be treated with chemotherapy and radiation, potentially sparing the oropharynx and structures of this area from getting radiation. We do remove these tumors when the tumor is relatively small and when the morbidity of surgery is felt to be less relative to radiation therapy. I want to assure you that the surgeon does the surgery. It's just the surgical robot which the surgeon here controls, but is somewhat remote from the robot, but controls the arms of the robot, allow the surgeon to get into small spaces that would otherwise require open approaches. So very often tumors of the aerodigestive tract revolutionized largely through the advent of treating oropharynx cancer. The surgeon is able to get into these small areas and manage these tumors when appropriate. I thank you for your attention. I know I've provided you with a lot of information about the common lumps and bumps that can occur in the head and neck. We talked a little bit about tumors of the skin and the common ones, as well as about a little bit about aerodigestive tract cancer and HPV-associated oropharynx cancer, which is endemic in the United States in middle-aged men. We also spent a little bit of time talking about lymphoma, which is another common diagnosis in the head and neck, as well as thyroid disease, goiter, and thyroid cancer. My name is Dr. Douglas Frank, and I am part of the Division of Head and Neck Surgery at the Zucker School of Medicine and the Department of Otolaryngology. I am part of a larger division, larger than is actually shown here. My associates that work with me in this region of the healthcare system are Doctors Kamdar, Pereira, and Gabalski, and we treat patients all throughout Long Island and Queens, and we are available for consultation. Thank you for your attention.